So I wanted to take you to one of my, two of the pet problems that some folks out in the community have. One is periprostatic infections, right? These are
Yeah.
after arthroplasties. And so, what is your approach to them? So, we get these for frozen. The question
Absolutely.
always is, how many chucks do you put in?
Hmm.
Where do you look? How many neutrophils? And I know you had this. So if anyone doesn't follow Scott on Twitter, you should, because he had
Thank
this
you.
tutorial
Yeah.
on infections in the periprostatic. Uh, uh,
PGI, periprosthetic joint infection. Yeah, you're exactly right.
yeah, yeah.
I believe.
And tips and tricks about how do you rule
Mm.
in or rule out that infection, and what's our role? The other question
Yeah.
I had for you is, when you pick up the phone and call the surgeon, what do you say? Do you say there's no evidence of infection, or do
Nope.
you
Nope. I
say
don't. And
you
then
call
yeah. No. It's a very good question. So first of all, I always tell people that your role as a pathologist is not to diagnose infection. If you think about how PGI, periprosthetic joint infection, gets utilized, and I'm thinking more along the lines of the MSIS criteria, where we have major criteria like a sinus tract or two positive cultures of identical organisms where it's made, our role to identify the histology that suggests this infection is a minor criteria. A minor criteria along with elevated CRP and ESR. We are minor criteria. We don't establish infection. We provide a piece of the puzzle. So it's really, I think even some surgeons are confused with that, but we promote the MSIS criteria as being, and I believe we have in the article that we wrote for
Yeah,
your
yeah,
journal,
I'll
we,
put
we
it
have a
out there
table.
as
Yeah. And so I tell people, think about your role is that you're not establishing infection. And basically by following those guidelines, I think the most accepted is the greater than 5 neutrophils in five, distinct, different high power fields.
Is it consecutive or just
No,
random?
it can be random. No, it can
Yeah.
be random. I don't think consecutive. And in many cases when it's very obviously infected, you'll hit 30 or 40 in one field, right? So you kind of, I count it all the time? No, but if I'm counting, we had the same discussion about mitotic activity separating D. diff liposarc from, well-differentiated liposarcoma at the last use cap. If you get down to counting, you're probably negative. But we do that because we still need some standard
Right.
criteria. So if it meets the criteria at frozen, I call the OR and say it is positive for significant acute inflammation, right? And if it's negative, I say negative for significant acute inflammation. Now you should know that when I first got to the clinic, there were some surgeons were actually saying, well, what is the count? The people would have to, 10, greater than 10, greater than 20,
Yeah.
So I had an opportunity, and in fact, Dr. Wright joined me this endeavor. We went and talked to the chair, we talked to the orthopedic surgeon, and we basically got everybody on the table, which was still amazing to me that we got a lot of surgeons to agree. But basically, we said, look, this is what we're going to do. We're not going to give you a count, but what we are going to do, and we're going to follow the MSIS criteria, which they like. If we use the word significant, that tells you it's greater than 5. Per 5 high power fields. If we say negative, it's less than that. And that way we don't get into focal acute inflammation. So I would, at the Cleveland Clinic, we also, all of us, even though we're so specialized, we also do general frozen section coverage.
Okay.
So, but you have backup. You always have a backup. So someone could call me or John Wright or Karen Fritchie, to come take a look at a case that they're worried is borderline or not sure if it actually meets the criteria. So it was in our best interest to try to get everybody educated and comfortable with the terminology. And so on my YouTube channel, I created a video, and it's funny, I've referenced that video on Twitter before, but that video was primarily made for our pathologists doing frozen sections at Cleveland. So
And
they
I'll
would
put the link
understand why
below.
because it was also a attempt to understand, well, why do I need to interpret this at frozen? What is an antibiotic spacer? Why are we what is 2-stage surgery versus 1-stage surgery? Why is this significant? So it was an attempt to educate them about that. But yeah, to answer your question, positive for significant acute inflammation and negative for frozen. And when I sign them out, I will say, significant acute inflammation suggestive of periprosthetic joint infection, or negative for significant, and that's all I say. One or the other. Sometimes I might add in, mostly fibrin or,
Yeah.
but that my line diagnosis, because I know how far the surgeons are reading, they're not getting past that one. So I want them to say it's positive versus negative, So,
Yeah.
but yeah, that's exactly how we handle it at the clinic.
And how many chucks would you put through at frozen?
Yeah, and that's a good question too. I don't know that there's a great answer. We typically, do one section, at frozen. We don't put the whole specimen in. We typically don't. We accept now. If you do that, you have to accept the fact that somewhere around 3 to 5% of all your cases you will have a positive result due to sampling that may have been missed at frozen. Now, whether it would have been picked up or not, I don't know, because we still see that occasionally, even if there's no other tissue to submit. In other words, all the tissue was submitted at frozen. But our typical practice is one piece per section that comes in. So if it's, for example, synovium number 1, synovium number 2, synovium number 3, they all get one section at frozen. And we don't usually submit all the remainder of it for permanence either. Typically one more additional section if there's tissue remaining. So we don't typically submit all of it, in that manner, unless there's something like, let's say it came in with a suspicion for alval or something like that, we might pursue that more. Although I've even started pursuing that diagnosis even less now too.
So, what happens if you do end up with neutrophils on the permanent that you didn't see on the frozen? Have you gotten a lot of pushback from the orthopedic side?
Not really. No, I'll say email them on every case like that. I let them know that, because one of the first questions is oftentimes, did someone miss something at frozen?
Right,
And I'll be quick to point out, no, this additional material that was not evaluated at frozen revealed significant acute inflammation. Most of the time, again, if the surgeons are using the criteria correctly, most of the time, if they really strongly suspect infection, they will handle it like an infection, and that is they have other parameters that are going on.
Right.
So the most common response I get is, yeah, no problem, I handle it like an infection anyway. Every once in a while they didn't. Now it's interesting because I've kind of wondered what happens to those patients, because those aren't patients that are typically, we're not talking about purulence here. We're talking about just some foci that meet the criteria. And we know that, when we set criteria like this, it's somewhat arbitrary. We're trying to establish a test with X sensitivity, X specificity, but it's not perfect. So there's going to be some cases we think are infected that probably aren't, and some cases that aren't infected that probably are. So you're going to have that kind of discrepancy, but they do accept the fact that we've got. I want to say last time I checked, we're looking at about 3%. At the high end, 5% of cases may have sampling error associated with it.
Okay. Yeah.
And sometimes I will say, when I say that, I'm also including cases in which we had multiple specimens and there was clear cut significant acute inflammation, and they may have had another specimen that wasn't, but in permanence it was. That would not have changed surgery anyway. So I'm including those kind of cases in there as well.
Right.